welcome to the third episode of the Right Podcast. I'm Minahil Khan. I'm a senior research fellow at the Research Society of International Law. Today, I have with me Mr. Usman Mushtaq. Usman Mushtaq is an advisor to the Ministry of National Health Services, Regulation and Coordination on diaspora and special projects. Usman, it's so nice to have you here. Thank you so much for taking out the time. And I believe you've been working at the ministry for about a year and a half now. And what a year it's been. So, just to start off, we'd like to know about your experiences here. I also know that you're Norwegian. And how has it been in Pakistan? How did you come across this opportunity? And how has it been like for you, especially during COVID 19?
Wow, thank you so much, Minahil. First of all, thank you for the invitation. It's a really interesting topic that you guys are discussing and working on. So, very brief introduction. I mean, I have a medical background, so I'm a medical doctor and a degree in economics. And in Norway, I've been working quite over a number of years on public health related issues, both on policy and politics, and environmental sustainability. So, I've done a number of things, both nationally and internationally. And one of the things that I had always in my back of my mind is, even though I've never lived in Pakistan, I wanted to contribute in whatever capacity that I could. And quite interestingly and unexpectedly, um, I had met with Dr. Zafar Mirza, who was the previous SAPM on health, when I was a young intern in WHO almost a decade ago. And we stayed a little bit in touch. And when he was appointed to the SAPM, he asked me to come and join his team. And initially I was just supposed to be here for a few months, and then it just got extended and extended, and suddenly the pandemic hit. And let me tell you, that changed absolutely everything. And it feels like we started working on this around mid-January, and it feels like it's been so many years, and every passing month feels like such a long time period. So it's been really intense. It's been a very sad moment for a lot of families that have lost their loved ones, people that have gone through tough times, in Pakistan and in other places around the world. We all know somebody that has been impacted. And However, the way that I like to think about this, for me personally, it was a challenging time, but professionally, it was a incredibly prolific time for me, where I was able to contribute in ways which I would have never thought would be possible for me at this stage of my career and my life.
Oh, but that's really inspiring, Usman, to see that you came all the way from Norway to Pakistan to be able to contribute at a time when we really needed people from, we needed experts from around the world to help us. Now, just moving on to like the more, in relation to COVID 19 and, with the emergence of diseases such as this, and in the wake of, their impacts, RSIL has been working on this for a while now, and we have a report that looks at the legal framework for health security in Pakistan. And when we were going through that, we realized that the impact of a health crisis, of a health emergency, is so intense and it is so profound, and it is so important for countries to be prepared and equipped to deal with this. In your opinion, how equipped and how prepared was Pakistan in responding to the pandemic?
Right. This is such an interesting question because not a lot of people were expecting that Pakistan would be able to grapple with a disease outbreak and a pandemic of this size and this intensity, right? And to be frankly honest, neither did we. Because if you look at and you have done some great work here. I have like this 200-page report from you guys. This is really awesome work. But if you look at the precursor for the pandemic and look at our health security preparedness, Pakistan was evaluated fairly low
Yeah.
in the external evaluations that took
Yeah.
place from missions that came from WHO, etc. And we had a significantly amount of work that we need to do in order to strengthen our health security. So in health security, it's not only the general health system, which is incredibly weak in Pakistan, so the
Yeah.
public side of things, but also very specialized elements, like your lab capacity, the way that you handle people
Yeah.
at point of entries, etc., etc. And there are so many elements to this. So Pakistan's ability to grapple with the pandemic was considered to be fairly low and on the same level as lower middle income countries, right? While high income countries have fared better in these indices and evaluations
Yeah.
that took place. Now, what we saw with this pandemic was a complete, I would say, disregard to the way that we have evaluated health security, especially and how we rank these countries. I mean, you saw that politics played an immense role
Yeah.
in how the pandemic panned out. But more than that, there were more issues than just politics. Like and in any evaluation that took place, nobody really considered the fact that America would have such a dysfunctional leadership, right? And while East Asian countries were able to handle this so effectively and so well, so we talk a lot about Wuhan and where the virus came from, and when the governments, so local authorities in Hubei reported it. But even if you consider the fact that you would have gotten a week or 2 weeks better preparations
Hmm.
time, it seems like the end result, specifically in Europe and in Western countries, wouldn't have changed because you had frankly speaking, a political leadership that did not take this seriously. So, for Pakistan's point of view, our health system is severely under resourced. We knew that we had a lot of gaps in our health security. So technically, we were not that well prepared.
Yeah.
However, right before the pandemic hit, at the federal level, we were dealing with a significant dengue outbreak, and we had a technocrat SAPM, which is functioning as a health minister, and a government that focused on health issues. And you had like significant actors within the government that were well aware of health related issues, like Dr. Sania Nishtar, etc. So coming from the dengue outbreak in autumn 2019, dealing with outbreaks were quite fresh in mind. And I remember very clearly, when we first started the briefings on COVID-19 back in 15th of Jan, actually was one of the first briefings that we had. Fairly quickly, we got on top of it. And much more rapidly, we managed to start developing systems on the go, systems that we did not have in place. So even though we were not, we were not well prepared structurally, but the intense focus in the initial few weeks ensured that Pakistan fared really well.
Yeah.
And we can come back to comparison to other countries, etc. But I would kind of come back to the fact that those first few weeks and months were crucial in our preparedness because we were not set up to succeed.
Yeah, no, I mean, even when we were undertaking this research, I mean, almost every literature that we read recently indicated that countries that did really well on these indexes like the GHSI and the JEE didn't actually do very well in practice, and weren't very as equipped as you would think they would be in dealing and in controlling the pandemic. And that really reflects the need to have good governance and good leadership. And I think in Pakistan's case, we really were, it was a good thing that we had already declared polio as an emergency, because we were able to use a lot of the machinery that we had in place for polio for COVID. And as you mentioned, for dengue, which we then used for COVID. But generally, in terms of the role of leadership and the role of governance, there have been issues in the past, especially with relation to devolution and the fact that we didn't have a federal ministry for so many years. So the ministry now is a fairly new ministry. How did it deal with issues of coordination, especially interprovincial coordination, which we saw was an issue at the beginning? How did you kind of, what were the processes that were then adopted to ensure better coordination? We saw the NCOC that was created, and how that worked with the NDMA and the ministry. But could you just elaborate on that a bit more?
Right. So just one quick comment on the ministry. So I mean, having the perspective from the outside. I mean, I've worked quite a lot in Norway and globally on some of these issues, and it's quite fascinating, how under resourced some of our departments are. I mean, the recurrent budget. So health ministry has two types of budgets. One is recurrent and one is development. And I'm sure some of your viewers or listeners would know about this. But the recurrent budget of the Ministry of Health, I'm from a local area in Oslo. Oslo is a capital of Norway, 700,000 people. My local neighborhood has 30,000 people, right? The recurrent budget of Ministry of National Health of Pakistan is lower than the primary healthcare budget of the part of the town where I'm from in Norway. Right? Like
Wow.
30,000 people has
Wow.
bigger primary healthcare budget than, just gives you the extent of how severely under-resourced health sector in Pakistan has been, and the total healthcare public healthcare budget isn't really something to be glad over either. So so the devolution played a devastating role in the way that health was managed. Uh, uh, I mean, obviously, the principles of devolutions were right, like healthcare, should be delivered closest to the uh,
At a
patient.
grassroots level, yeah.
Right, like, so all of that was correct, but the way that it happened, I mean, there are not a lot of international examples where you see overnight that the Ministry of Health is gone. Pakistan was, in that period, I think between 2008, 9, 10,
2010, yeah.
10 to 13,
Yeah.
was the only country in the world that did not have a federal Ministry of Health. Now think about that. So, the UN, World Bank, etc., said they had to send missions to Pakistan, try to convince the leadership that, for God's sake, you need to have something central on health. Education is, the same issue. So basically, what that did was that evaporated the institutional memory, and it had to build up from the bottom up. So so the ministry, I mean, I have really awesome colleagues. People are working really, really hard with very few resources, and it has, obviously, for them, being a very severe challenge to build some of the institutional memory and some of the working capacity up again. So when COVID hit, coordination among provinces was a challenge. The precursor for the NCC, the National Coordination Council for, or Coordination Committee for COVID-19, was that the Ministry of Health actually took charge. We were supported by various entities, and we had a regular, I think, a weekly or a weekly meeting with chief ministers and health ministers. And this is, now we're talking about like end Jan and Feb. And then, when the National Security Council happened in 13th of March, I think it was, uh, uh, we advocated for that, we needed this kind of mechanism. And that was when the NCC was created.
Yeah.
So the NCC, the National Coordination Council, was the political coordination committee for all things COVID related, and it was chaired by the PM himself. So the PM, all the chief ministers, relevant federal ministers, armed forces, etc., like everybody that was, involved in the response, was in the NCC. Very soon, there was a realization that on the political level, you needed still an operational arm.
Yeah.
So the operational arm, I mean, the Ministry of Health was, could have done it, but did not have the right amount of resources and not the right amount of clout within, the provinces as well. So that's when the NCOC was created, like a joint civil military nerve center for COVID response, led by very strong minister Asad Umar Saib, and Lieutenant General Hamoud, basically. So the NCOC became then the operational arm of the political committee that the NCC was, and it worked. I would say wonders
Yeah.
for the early response, and boosting up Pakistan's health capacity, and also a response towards COVID-19.
Okay, no, so that's good to know, and I think, but does it? I feel the creation of the NCOC also shows somewhat of a reactionary approach that the government had to take, because
Yeah,
we didn't have the machinery in place. We do have a National Disaster Management Authority. We have an entire
we have
setup for that.
PDMAs.
We have PDMAs. We
Yeah,
have DDMAs as well.
yeah.
But with the creation of the NCOC, I feel like did we not in some ways undermine the role of those statutory bodies and that entire statutory mechanism that had been created to deal with emergencies of this nature? And while doing this research, I think what really came about was the fact that Pakistan also did well on, on some indicators in these indexes relating to, linking with security personnel and in relation to our response mechanism, because we had already been hit with disasters. So when we were being examined and when we were being assessed, we were using that statutory mechanism. But then when we had a health emergency and when we had this crisis, we had an entirely different mechanism that we used.
Hmm.
Um, and I just really want to understand how how do you reconcile the two? How do you reconcile the NDMA with the NCOC?
Okay, so a couple of things there. And one thing that I really want to mention is that if you remember early on, there was a lot of politicking around COVID response. Sindh is doing this, Punjab is doing the other, Prime Minister is saying that,
Mm,
but somebody is saying that. I'm sure your listeners will also recall this. Now, the interesting thing is that these coordination mechanisms, what they did was that they streamlined the response in a way where even if politicians were going on TV and saying XYZ, the response at the back end was completely streamlined and harmonized, right? So so at the NCC, you had the political leaderships, the chief ministers and the prime minister and the federal ministers, while at the NCOC you have the chief secretaries. So you have the response side, you
mhm.
have the bureaucratic side to the response, and I think that was a complementarity that the Ministry of Health or any other federal ministry would have struggled to gain, because it's just a very very difficult task to do. Pakistan is a big country, and not all the countries that haven't had the same structure have managed it very well. I mean,
Yeah.
we can look at to our neighbors, for instance. So to your question, technically, who should be doing this? Yes, of course, it's a pandemic. I mean, it's a disease outbreak. It's Ministry of Health is in the lead. However, this pandemic was so all-consuming that
Yeah.
it impacted every single facet of Pakistani society. Every single
Absolutely.
facet.
Yeah.
Hence, why it is unnatural to think that the Ministry of Health can be in lead of that, because there were questions related to industry, questions related to poverty,
Yeah.
questions related to so many other things that is much more beyond the
Yeah.
purview. Hence, why you needed a structure that was beyond one ministry.
Yeah.
So I think technically, yeah, disease outbreak is our work. Lekin the COVID-19 pandemic was something very very different, and the NCOC grappled with all kind of issues, and that is, I think, that created the harmony.
Mhm.
Um,
Yeah, so just
yeah.
taking from there on the effect and the impact that COVID-19 had on almost every facet of life, we can see that the negative impact of this pandemic was more profound and particularly worse in areas where there's high poverty, where there's poor governance, and where there's a concentration of marginalized groups. And what is the ministry doing right now to tackle that?
Right. So, by the way, you had another question in terms of NDMA and
Yeah,
their
yeah, yeah.
setup. So, NDMA's main role in this became that NDMA became a vehicle for how we could do emergency, because a lot of response is related to how fast you can bring in equipment
Hmm.
and how fast you can bring in not only diagnostics but also treatments, etc., right? Like, so NDMA initially, because the procurement mechanisms in the government are slow, and they're very rigorous. NDMA could step in because we invoked their act, and they could fast track that.
Yeah.
Actually their role was also very harmonized, right?
Hmm.
There's a division between the actual health response, which was carried out by the health authorities.
Yeah.
So in for instance, Islamabad, it's the Ministry of Health that did the contact tracing, that did ran the
Yeah.
hospitals, that the district health officer, etc. Same thing in the provinces, while NDMA is supplemented with procurement. So that's
Hmm.
like kind of the bifurcation that took place. NDMA itself could not deal with that. So the outcome of this is that now there is a even more holistic view of coordinating with when it comes to disasters of this scale,
Hmm.
and this NCOC created a model for how to do that. So that will be more streamlined in the future. Now, secondly, in terms of marginalized communities and how to reach that, I mean, you're absolutely right. Like, COVID-19 is a disease for it's a fairly urban phenomenon. You see it in villages as well. Like, and it hits places where a lot of people live very tightly together, and where people can't do social distancing because they gotta work their daily wages,
Yeah.
etc. So very cognizant of that. And early on, what we tried to do was that we looking at models from other countries was that we tried to set up test centers
Hmm.
in urban slums in certain areas in Karachi. I mean, obviously led by the provincial governments. Same thing in Lahore, where we felt like there was hotspots. So we tried to bring the health service delivery at the doorstep.
Hmm.
It's a very difficult thing to do. Now, the second thing that took place beyond the health service delivery was the Ehsaas cash handout, which is the biggest in Pakistan's history, and the way that it was coordinated, I think it was a great success
Yeah.
for the government. And also the policies that were designed to mitigate for COVID-19, just called non-pharmaceutical interventions, कहते हैं, NPIs.
Yeah.
They were also very targeted to avoid economic damage on the most marginalized communities. There's a reason why the prime minister was going around and saying, "Hey, a general lockdown in this country will lead to an increased level of poverty, which will lead to increased level of undernutrition, etc., etc., etc." So with those three methods, we try to safeguard our vulnerable community. Like in still, I mean, there are still the ones that was hit the hardest. They're still the ones that had experienced the highest numbers of infections, even though
Yeah.
we're not able to catch all of them. And unfortunately, that's the nature of this disease.
Speaking of the prime minister and how he, opposed a full lockdown, what is your opinion now on ending all COVID-19 related restrictions, considering the fact that our population is still not vaccinated and COVID numbers are still there and COVID is still very real?
Yeah, I mean, we haven't ended all restrictions. Masks are still mandatory. I
Hmm.
mean, there's another question that if people, are wearing these things or not, but masks are still mandatory.
Yeah.
Social distancing guidelines are still mandatory. So the general guidance to the public is still valid, and we try to push that. However, there is a I would say that in the public now, the risk of COVID-19 is not seen as big of a
Yeah.
threat as it was seen in March, April, May, June, right?
Yeah.
And that is very sad because obviously compliance levels fall very, they fall. So what we're seeing at the moment is that the disease prevalence has decreased. However, as you probably read in the news as well, there is emergence of uh, variants,
Yeah.
SARS-CoV-2 variants, like so the virus variants, which are more transmissible. We got it from travelers from the UK. We put in severe restrictions there as well, and the likelihood for that the disease might resurgence
Mm.
again is there, and we're very aware of that, and what that would lead to would be a corresponding match of re-implementation of
Okay.
NPIs. And I think it's difficult to get that message across that if the virus rises again, there will be no other ways than like doing all the restrictive measures which
Yeah.
harm the economy, which harm our children, right? Like, I mean, we don't talk about that, like in uh, school closures. I'm not sure if your listeners would know, but like 55 million kids, young people and adolescents, go to school or high school or university every single day. That's like one fourth of the population, much higher than in many high income countries.
Yeah.
And stopping that has for especially the youngest children, it has a lifelong consequence. So unfortunately, I think we're not this is not the end of the disease, even though we're seeing that vaccines are going to come in. This is going to surprise us in ways, and we're aware of that. So
Yeah.
all COVID-19 restrictions are not lifted, and most likely they will start getting reimposed as the virus resurgent.
Okay. Okay, so that's, I think that's good to know, the fact that the ministry, the government is very cognizant of the fact that there can be a resurgence, and I think, but again, I think the responsibility is also on the general population right now upon wearing masks and ensuring social distancing, and we've seen that people have also become very complacent, and I think news of a vaccine is also something which has given everyone a lot of hope. But in terms of that, I would just like to know more about the rollout plan for that, especially in relation to how this is going to go to those who are in rural areas where there is already very limited health infrastructure. What is the vaccination program, and what is the rollout program for that?
So we're embarking on the most ambitious health outreach program, I think, in the country's history. The idea is to vaccinate to achieve herd immunity, which, from our current understanding, would be anywhere between 70, 80 million people. That's what Dr. Faisal and also Umar Saib have also been, I think, saying publicly. I mean, that's our current understanding. It might change with time. And currently, what we know, what we have secured, is roughly 45 to 50 million vaccines, and more will be secured with time. The large scale rollout to the general public. So currently, at this moment, I'm not sure when this will be published, but at this moment, frontline healthcare workers and healthcare workers can easily go get themselves vaccinated. So frontline healthcare workers can just walk into any vaccination center and they'll get the vaccine. And healthcare workers in general, and we're not only talking about doctors, the nurses, paramedics, allied health professionals, etc., people working in clinics, um, they can register themselves, and they will get an appointment and get vaccinated. Uh, in this month, we will start mass vaccination of people above the age of 65. And then we will gradually go down the age, like 65, 60, 55, 50, etc.,
Okay.
etc. So we anticipate, so one of our biggest challenges that we foresee will be a high degree of resistance within the public on getting the vaccine, and that will be some of the things that are, we're working on a large scale program to mitigate for that.
Yeah.
It will be a huge challenge for us. The logistical operations of rolling out the vaccine, it's complicated. However, we've done it before, right?
Yeah.
I mean, 4 times a year or 5 times a year, we we run the national polio campaign, which vaccinates 40 to 50 million kids in 5 days time or 6 days time. These massive vaccination campaigns. So our infrastructure also in the rural areas is robust.
Yeah.
The focus initially will be in the urban areas where you have a lot of population and where the risk is also the highest. So it will be a semi usage of our existing health infrastructure. Then also on top of that, we're working on some innovation with the private sector as well.
Okay.
So because the rollout will need to be, we're talking about, like, if we want to vaccinate like 60, 70 million people by the end of the year, or even 50 million people by the end of the year, we're talking about, like, several 100,000 doses a day that needs
Okay.
to
Wow.
that needs to go out. So
Yeah.
we're planned for that.
And this will be done through the EPI?
EPI will be in charge,
Okay.
and EPI is the front leading, but
Mm-hmm.
it is, obviously coordinated by NCOC, led by Ministry of Health, with EPI, and EPI is fairly capable to do this.
Okay.
We have the logistical infrastructure, and then obviously it will be supported by our partners, and also hopefully the private sector once we get going.
So generally, in terms of health security, there is a response. Like the idea is that you should be able to prevent an outbreak of a communicable disease. Then you should be able to detect cases of that communicable disease, report them, and then also respond to this. So you're basically looking at your entire state machinery when you're looking at health security. But in terms of detecting viruses, in terms of detecting diseases and reporting them, um, how do you think Pakistan has done so far, and what is the role of the NIH in this?
Mm.
And now that we're looking at the restructuring of the NIH, what do you think? What do you foresee for that? And could you just explain that to us in?
Right. So let's talk about NIH restructure first. It was an ordinance that got passed a month and a half ago, I think
Yeah.
now, and hopefully will turn into an act. Basically, that is a conclusion of a long-standing work of making the NIH fit for the 21st century,
Mm-hmm.
and with the onset of the COVID-19 pandemic, making sure that our NIH is robust enough to handle these things, and also have the in-house capabilities. Now, NIH has played a tremendous role in COVID-19, for the fight against COVID-19. The lab guys, they've been working day and night. Pakistan was one of the first countries, low and middle income countries, that had capability of diagnosing SARS-CoV-2. Um, and NIH helped. labs all across Pakistan to be able to have this capability of actually running PCR tests. I mean, now there are more than 140 or 150 labs, and they're supported by NIH, or have been supported by NIH, and we're running quality controls, etc. So on the lab side, I mean, NIH has done a tremendous amount of work. Then on the contact tracing side, there is an entire unit in NIH that looks at the academic side of things, like how contact tracing is supposed to be, and they have done numerous trainings, like in provinces, in districts, going down training these rapid response teams, etc. So even though it's not been kind of visible out there like as a newsworthy thing, but at the back end, NIH has played a critical kind of role, an enabler. The restructure of NIH, the most important thing in that, and there are many important things in that, but the most important thing in that, in this context, would be the creation of CDC Pakistan, so Center for Disease Control Pakistan, which will be modeled after the most advanced CDCs across the world. And the idea there is that we want to build a hub within the NIH, within the CDC, that are not only Pakistan leading but world leading experts on these issues. So the restructuring process is well underway. A board of governors, it's going to be an autonomous body with very capable board of governors that has been established, and the restructure process will then roll out in the next few weeks and months time. So the minister, Dr. Faisal Sultan, is actively working on this, and you have a lot of people involved in this. That's one of our main objectives in the reform agenda. So high hopes for NIH, and we think that if there is something good that is going to come out from this, is these kind of reforms, and particularly NIH, that will, I think, receive a tremendous boost from having a lot of people that have been involved in dealing with the pandemic that can go straight in and build our long-term capabilities.
Okay. Um, to come back to something that we discussed earlier, which was that, Pakistan was perhaps the only country to not have a national ministry of health at one point in time. Right now, we're also one of the very few countries in the world which doesn't have a right to health in the constitution. And how do you think that affects our programs? And because we see that a lot of them then are not sustainable, or because of the lack of a constitutional right to health, many of these are then abandoned midway. What is your opinion on that? And generally, could you explain this to us in relation to vertical programs and how those work, and how the lack of a right to health affects these vertical programs?
Yeah, I would say that it's sad that the right to health is not enshrined in Pakistan's constitution. I know that there has been efforts. However, I mean, with the current political polarization, it's kind of hard to see anything passing anytime soon, right? Um, there has been, I would say, the politicization of health issues, I think, has been important. And I know, that might sound bad, but the fact that you had a government running on the agenda that we will improve health is remarkable in Pakistan's history. So there is an increased focus. Now, the interesting thing is, if that doesn't really translate into actual investment into infrastructure and actual investment into systems, governance, and then the programs that you're mentioning, unfortunately, if you take almost any disease, it will show the negative. It will show a bad trend in Pakistan, right?
Hmm.
Infectious disease. I mean, we're like the second fastest growing HIV epidemics in Asia is in Pakistan, right? Pakistan has the highest burden per capita on hepatitis C, right? We're not able to grapple with tuberculosis, etc., etc.,
Yeah.
etc. I mean, so there are just so many issues, and a lot of these vertical programs, and particularly AIDS, tuberculosis, malaria, I mean, they've been driven by strong support from partners, donor countries, donor organizations, and the ownership from the government has been with limited funding, and that has to switch. And the Prime Minister's Health Task Force, which is led by Dr. Nushairwan Barki, and has had this as a core front, that investments into health needs to increase, and there are some critical things that we need to hit.
Hmm.
So there is a realization now that we cannot only rely on donor funds to do health. That has to be our own money.
Yeah.
Sehat Sahulat program, I mean, the health insurance card for especially chronic disease, that is being expanded by government's own money. Government is actually spending money on this. A lot of these vertical programs now are getting more sustainable funding. So the PC, once the development projects are in place, so a lot of these things are in priority. And I think even if right to health was enshrined in the constitution, I'm not necessarily sure it would have produced a different result. But I
Hmm.
think that it is morally important that the country has it. But the actual investment comes from the fact that there is prioritization. You can't
Absolutely.
you can't expect you can't expect that these indicators that we're talking about,
Yeah.
stunting, undernutrition, chronic disease,
Yeah.
non-chronic disease, sorry, and communicable disease, etc., that any of these things will get better if you don't invest into the systems. So um, uh, Ministry of Health is planning along those verticals that you mentioned. So on communicable disease, it's very clear. We know what the asks
Hmm.
are. On other types of health issues, particularly on nutrition, there is a lot of focus on that. The Prime Minister has made it his flagship issue. We're developing the largest PC1 in social sectors in
Hmm.
Pakistan's history, 320 billion rupees, which is now in its final stages. And that will start rolling out, which will target stunting and wasting among children, in nursing, etc. So there are a lot of things that are coming up.
Yeah.
And the only thing that I think can hamper this is that political uncertainty in Pakistan is a reality, and it's a fact. And if you have a lot of political uncertainty, and if you have changing ministers, changing governments, etc., over long periods, I think that will continue to hammer our health indicators. So that is a major, I think, uh, 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 yeah, it can be a major
Yeah.
barrier.
So taking from your point on all on these issues, and then on especially on health indicators, and then discussing universal health coverage as something that Pakistan is aspiring to achieve. My only concern and a question to you is that, considering the fact that we don't have the basic health infrastructure right now, and considering that our health service, the fact that we have a very decentralized service delivery system, but one that is riddled with issues, how do you think how do you think universal health coverage will affect that? How will it change any of that? Is it just something that will we just be ticking a box that, okay, we have universal health coverage here, without, can we do it without the actual adequate infrastructure for it?
Um, I think, or I know that this is not just a academic exercise.
Okay.
The work on universal health coverage, and I'm very glad that you brought that up, has been really important in Pakistan's case, where Pakistan has over the past few years taken a front seat in identifying what is it that we can do with certain amount of money that would produce the best health outcomes.
Mm.
That has been a multi-year long effort, and the conclusion to that is actually very tangible. So the tangible in this sense becomes, what are the type of services that we need to deliver at the primary healthcare level?
Mhm.
What are the services that we need to deliver at the secondary level, at the tertiary level, at the community level, and at the household level, like with
Mhm.
LHWs, and community workers, etc. We have the framework. Now that's a huge thing, and the implementation of the framework, it's not that expensive. So the health infrastructure, like the brick and mortar,
Mhm.
is actually, we're not too bad with that. I mean, if you go to Punjab, they have thousands of BHUs,
Yeah.
basic health units, right? So the brick and mortar, yes, it's a but the more important thing is the software. Like what goes in, like what type of services are we giving? For instance, if you get a sore throat, everybody goes to PIMS,
Yeah.
which is a tertiary healthcare system. Technically, you should go to your local. So a lot of that, within the universal health coverage model, will be sorted out, and in Islamabad it will be rolled out. I mean, we have the money for it, we have the system ready,
Yeah.
and inshallah, over the next year or 2 years, when you start seeing the rollout, this will end up becoming the model, which provinces are already excited about this, because they
Yeah.
already want to pilot it in districts. So I don't think it will just be a tick
A
and we're
check in
done
the,
there.
yeah.
No, this will be the slow paced evolution that we require in expanding
Yeah.
health services to people. and it will cost money. That will automatically entail that we need to spend a higher proportion of our GDP on healthcare issues, which I hope that our decision makers are comfortable with.
Yeah. No, that's definitely good to know, and that's very encouraging to hear as well. Because I mean, right now, as you mentioned, that a lot of people, when they have a sore throat, will go straight to PIMS. But a reason for that is also because your BHUs are right now not equipped to handle even a sore throat. Because when you go there, they're usually empty. Your workforce distribution is tainted, and at the moment, as long, I mean, pursuant to the studies that we've conducted, we've seen that with many of these areas, you don't even have the workforce, and you don't have skilled technicians, you don't even have people in the laboratories, your lady health workers are severely stressed. um, so there are these issues, and I really
Hmm.
hope that through this universal health coverage program we can address some of these. And I'm hoping that with an improved service delivery program, with improved health infrastructure, we'll be better equipped to deal with a health emergency in the future as well.
Yeah, I 100% agree with you. And if you get a sore throat, you won't go to the BHU. You will go to the private service provider, because that's like what 70% of Pakistanis do.
But I think that's the biggest problem right now. The fact that, so we have an entirely separate unit right now, a private unit which is not really regulated. So even when you're looking at, I mean, when we were studying data surveillance and integrating that data, the biggest, whenever we spoke to anyone, even in the ministry outside, their biggest complaint was the fact that it's so difficult. Everybody's using every hospital is using a different software. It's so difficult to integrate all that data together, to bring it together, simply because you have so many different systems going on in the same country.
Yeah, but we so you're absolutely right. Like, I mean, you will data harmony is I'm not going to say it's impossible, but it's going to be incredibly hard for a country with almost a quarter of a billion people. So let's just get that straight. However, COVID-19 showed that things are possible. We have a central repository for where we know where, all the test results that comes in, we know who's positive and who's negative. And that kind of informs the response from the central to the provincial to the district and UC level. So it is possible. It just requires a lot of work and a lot of resources. But I would say that the private sector will end up still playing a significant role. It's the regulation of the private sector that will be important. Islamabad recently constituted the Islamabad Health Regulatory Authority. I mean, it's still very, very in its infancy. But the point here is that we need to regulate the quality at the private sector, and then we need to provide quality services at the public sector. And one thing that I would like to say is that, as I mentioned earlier, so universal health coverage is vertical, like cross-cutting, right? Yeah. But sorry, it's horizontal. It's cross-cutting. But the vertical programs, the strengthening of the healthcare system that happens through vertical programs are also important. So technically, we need to look at everything that is going on into a single umbrella. So, for instance, the nutrition program that I was talking about, a large chunk of the nutrition program goes to strengthen service delivery at the household level. So we're talking about like strengthening lady healthcare workers. We're talking about providing nutrition services that can either at the primary level or at the household level. So I think for people, and I know that there's not a lot of information about this outside. However, and we need to get better at communicating what we're actually doing, but there is a collective effort that is going on. But the sticking point will end up being, show us the resources, like prioritize this or else they won't.
Absolutely, yeah. 100%. I think health is definitely something that has been ignored for far too long, too many years now. And I think COVID-19 has sort of really brought that point home that, you need to give this more priority, because it really affects every aspect of your life. And but Usman, on that note, just wanted to say it's really reassuring, and it's really good to know that we have people like you working with the ministry inside, on the front lines. We usually hear of people from Pakistan going abroad, and it's very rare that we hear of somebody who studied abroad, lived abroad, coming back and working in Pakistan. So that's great to know. And I just wanted to thank you for taking out your time and for talking to us about these issues. There's so much to discuss, and honestly I feel like we've only reached this is the tip of the iceberg, and I really hope that we can have you here more often to discuss all these issues, because as you said, the ministry is doing a lot of work, people just don't know about it. And in terms of communication, I would love to be able to, I think we're in a position where we can help in that way. And for that, feel free to come back here and we can discuss as many other issues as they come. And yes, on that note, I'd just like to say thank you, and I'd like to thank our listeners as well who've been a part of this. And if there's anything that you want to say in the end.
No, thank you so much, Minal. And I really appreciate that you're actually, taking time and effort to discuss topics like this. I think this is, what kind of, obviously, your listeners will be very educated people that would be, well informed. However, we have a job to do to get the message across. And I have to say again, I think the work that you've done, and the work little that I've seen with the legal framework on health security for Pakistan and the report that you produced. This is groundbreaking stuff, and congratulations for that. I'm really excited to read the 200-page report.
Good to know. No, but thank you, and take care.
All right.